Hello everyone. I'm Dr. Zeinab Moubadder. This is my co-resident, Dr. Olga Chagan from New York Community Hospital. And today we will be presenting the case of a first metatarsal phalangeal joint arthrodesis failure in a non-compliant patient. I'll begin by going over the timeline to give you a general idea of the series of events moving forward. The patient initially presented on August 15, 2019. We are currently still seeing this patient, but the last procedure performed on the patient was January 12th, which was removal of an external fixator. So on August 15, a 57-year-old male presents with severe burning, radiating pain to his left foot that is ongoing for 3 weeks without improvement. Pain is worse at the first metatarsal phalangeal joint, aggravated by ambulation. He denies any trauma. Past treatments include steroid injections into the first MTPJ of the left foot and custom orthotics. He was referred to the attending physician for a surgical consult. He has a past medical history of AFib, prior right ankle ORIF. He's a social drinker, a current everyday smoker, works as a driver, is a gym enthusiast. On physical exam, vascular and derm were within normal limits. He has hallux rigidus left worse than right, a dorsal prominence of the first metatarsal phalangeal joint, pain with passive dorsiflexion, pain with palpation, the plantar lateral hallux radiating to the lesser metatarsal joints, and for neural gross epicritic sensations were intact. Initial radiographs, you see here a prominent degenerative osteoarthritis of the first metatarsal phalangeal joint. There is a dorsal flax sign, a first metatarsal elevatus, midfoot degenerative changes. After the first initial visit, the patient was pre-op cleared by his primary care physician and started on Chantix to quit smoking. And patient was scheduled for his first procedure, which is the first metatarsal phalangeal joint arthrodesis, on September 25th. So a linear longitudinal incision was made medial to the EHL. All osteophytes and bony protuberances were removed from the first metatarsal head and the base of the proximal phalanx. A cup and cone reamer was used, followed by subchondral drilling and fish scaling. A cannulated 4-0 striker screw was placed across the first metatarsal phalangeal joint. An anchorage dorsal plate was placed over the joint, and intra-op fluoroscopy confirmed the position of the great toe. And these are the follow-up x-rays. So just 1 week post-op, the patient notes he returned to sneakers and has returned to the gym to lift weights before being advised. He also admitted to smoking a pack a day, never really planned on quitting smoking. So this was 1 week post-op. Luckily, you can see the toe is still rectus, the dorsal plate fixation of the first metatarsal phalangeal joint with a cannulated screw noted medially. There's still great compression and fixation noted, okay? But 1 month later, after post-op, on October 25th, 2019, you can take a really close look. You can see that the dorsal plate fixation shows interval fracture of the plate overlying the distal first metatarsal portion. No fracture through the screws. The proximal and distal screws themselves are well fixated. There is some moderate tissue swelling noted. Okay, and on November 14, visit after visit, this patient has been, we're telling them non-weight bearing, use your crutches, stop smoking, stop going to the gym. But he presented on November 14 with pain getting worse. He states there is mild area of drainage from his toe and his big toe is swollen. Physical exam shows peri-wound erythema, a new pinpoint ulcer at the entry of the compression screw with prominent screw head, serous fluid expressed from the ulcer, swelling and tenderness around the fusion site with mild motion of the first metatarsal phalangeal joint. The treatment in office was to remove the compression screw, and he was sent to New York Community Hospital for IV antibiotics and removal of broken hardware. So these are the pre-op labs that were taken on November 14, the same day as the office visit. His labs show normal white blood cell count, no left shift. Due to localized infectious disease, they put the patient on vancomycin 1 gram every 12 hours and cefepime 1 gram IV every 8 hours, and the patient was moved for surgery the following day. So the next day, during the surgery, the incision was made over the previous incision down to the hardware, which was removed. As you can see in the picture, heavy metallosis was noted to be present where the hardware was removed. The area was flushed and the and a bone curette was used to remove the metallosis. A bone culture was taken, and finally the Stryker manual X-fix was applied. And these are the post-op X-rays. As you can see, there's good alignment and compression noted. A bone biopsy that was taken revealed staph epidermidis. The patient was sent home in a posterior split in clindamycin 3 times a day for 4 weeks. Okay, come December, things escalated pretty quickly. On December 12th, the patient continued to go to the gym, that was just 1 week, dropped the plate on his foot at the gym and dislodged the manual distal pin clamp. On December 17th, the external fixator was repaired in the office. Physical exam shows mild motion of the first metatarsal phalangeal joint. At this point, a bone stimulator was ordered. On December 26, 2019, this picture was taken. There's stable appearing lucency at the first metatarsal phalangeal joint, but without significant bony bridging appreciated. So the patient was then taken to the hospital to remove the Stryker manual X-fix on January 12th. This is after the X-fix was removed. As you can see, there's mild sporadic changes with multiple well-corrugated lucencies seen in the first metatarsal and the first proximal phalanx, consistent with residual pin tracks from the removed hardware. There's no acute callus formation, but there's also no destructive osseous lesions. So at this point, right now, the patient will continue using the bone stimulator ambulate with cam boot. Patient will need to stop smoking for at least 3 months before any surgical intervention. We were actually told today that he was actually seen in the office on Thursday ambulating in sneakers, but there was no pain, no range of motion of the first metatarsal phalangeal joint, and the pinholes have closed.